Welcome everyone to VMR tonight. My name is Rebecca Berger, and I am here as a guest host tonight. So thank you to all the CP Solvers OG crew for having me tonight. We really look forward to discussing what I hope will be a super interesting case tonight. I'm here along with Robbie. I think we have a case presenter actually already identified tonight, and that's Lori, if you're on. I'm popping through to see if I can find you. So whenever you're connected, feel free to unmute and introduce yourself. But as always, we will be in search of two case discussants. So if you're somebody that has been tuning in and hasn't jumped in yet, tonight's your night. We look forward to having you. So feel free to pop your name into the chat if you're interested in discussing. Lori, are you on to introduce yourself?
Yes, I'm here. Is everyone listening to me well?
Yes.
So my name is Yuri. I'm a last year medical student here in Salvador, Brazil. And I'll be presenting the case tonight. Nice to meet you guys.
Excellent. Thanks so much. Can't wait. Okay. Robbie, do you have a minute to reflect on some weekend gear?
Absolutely. By the way, I love that. I love that reminder that I should keep it to a minute because, oh my God, the floodgates were unleashed in terms of learning this weekend. But I'll keep it short and sweet. So on Saturday, we had a fantastic conversation. And for those of you who are tuning in now, on Saturday, we reflect on cases as in the usual way, but I tend to involve this chat. But most importantly, have an environment that is really focused on highlighting the global aspect of clinical reasoning. We'll have everybody from all across the world, especially folks for whom English is not a primary language. And we nerded out a lot about on Saturday and Sunday about inflammatory diseases in general. And I will tell you that the focus of the conversation was to talk about, hi, I have a puppy saying hello to me. Hello. That is on tape. Isn't that cute? The focus of Sunday was to reflect on disseminated lymphadenopathy specifically, and there was themes of inflammation on Saturday that we'll talk about in a moment. But Saturday was a case that really has many dimensions to it, but it was hard not to focus on the fact that there was disseminated lymphadenopathy. And I think all on UpToDate on the CP Solvers website, you'll find systematic approaches to disseminated lymphadenopathy. And part of my reflection was to say, like, what does the treating clinician do, or the diagnostic clinician do, when faced with this problem in terms of what tests she orders in a sequential manner? And that's a question that comes with it inbuilt the recognition that most lymphadenopathy that isn't diagnosed with a cursory analysis using blood work and some basic assessments requires a biopsy. And often we're at a tangent where we're like, oh, I've done my evaluation, NOS, and I don't have an answer, so I'm going to take a piece of the lymph node out. So we'll reflect on two parts of that. One is, how do you take that lymph node out? What are the ways you can do that, and what does that mean about your diagnostic yield? But more importantly, how do you arrive at a conclusion that the next step should be to take a lymph node out? And that's when you have to do due diligence to the things that you can diagnose through more simple means like blood testing and medication review. What medication review do I mean of? You should never miss a cause of drug-induced hypersensitivity syndrome causing disseminated lymphadenopathy, because the key is going to be looking at the skin and looking at the med list. So that doesn't need a lymph node biopsy. How else can you get away with a lymph node biopsy? You can diagnose the one notorious autoimmune disease that causes disseminated lymphadenopathy that is picked up on serology, and that is lupus. Now, don't get me wrong, there are many other causes of autoimmune disease that cause lymphadenopathy, but you're not going to pick up sarcoidosis or IgG4 disease or others through serological tests. So make sure you send an ANA and other tests for lupus. So right now you're doing the MedRec, you're sending an ANA and other lupus tests. And often the tension is, what infections should you look for? And really there's three overarching themes of infections to look for. There's the mononucleosis-like infections, which usually pivot to EBV, CMV, and acute HIV. You should think about those and probably test for most of them in the case of disseminated lymphadenopathy. And that's one big category. The other big category is granulomatous diseases. Now, the granulomatous diseases is an overarching term to refer to a number of infections, but there are a subset of granulomatous diseases that have a particular tropism for lymph nodes. These are diseases that will show up more in lymph nodes than they show up anywhere else. And that list is Bartonella, tularemia, mycobacteria, and histoplasmosis. Like those four, if the center of gravity of a case is actually the lymphadenopathy and not the whopping spleen or not the whopping pulmonary infiltrate, those organisms tend to disproportionately affect lymph nodes. Again, those are Bartonella, tularemia, mycobacteria, and histoplasmosis. There's one notorious mimicker that is so easy to forget about, and it's the one non-granulomatous infection, mononucleosis-like infection that can cause disseminated lymphadenopathy. And in true form, if I really want you all to remember it as well as I possibly can, I won't tell you now. I'll instead tell you at the end. So tune in for a wonderful case by a dear friend, Yuri, from El Salvador. And I'll pass the mic back to Rebecca to introduce our discussions if we have any. I have not looked at the chat because I'm staring at the puppies that I'm around. So forgive me if I ramble too long. But back to you, Rebecca.
You don't have to apologize if you show us the puppies.
All right, here you go. So I don't know if I'm on my phone. So this is a dog park, and they are many puppies. That is my puppy right there, being not so nice to that dog. But you know what?
Amazing. So we do have two discussants, which is fantastic. We have Oppie and Taylor. Oppie, can you go ahead and introduce yourself? You said it's your first time, so just tell us where you're from, kind of what stage in training you're at, and we'll take it from there.
Hi, so my name is Appy. I'm originally from Thailand, but currently I'm a first-year intern in Cambridge at Mount Auburn Hospital in Cambridge, Massachusetts. Nice to meet you.
Awesome. Thanks so much, Oppie, for joining us. And Taylor.
Hi, I'm Taylor. I'm a PA in internal medicine, and I think this is like my 6th or 7th VMR or something, and I've discussed a few times, but I'm on a break right now. So I don't know if anyone else feels this way, but I always feel like if I take a long stretch off from work, I'm gonna forget everything, even though I know I'm not. So I was like, this is a good time for me to come to VMR in the evening. So I always try to discuss while I can to just exercise my brain, and especially during this stretch off. So.
Absolutely. Thank you guys so much. We're so excited to have this group. So Yuri, you have it's Yuri, is that right? I want to make sure I'm saying that correctly.
Oh, sorry, my microphone was off. Yes, Yuri.
Yuri, perfect.
Yes.
You have a case. How many aliquots do you have for us?
I have 4 aliquots.
Perfect. And then the final diagnosis is number 5, is after 4? Or it's during 4?
Well, yeah. Diagnosis is it's not number 5.
It's after.
We'll give it away. Yeah.
Perfect.
Yes, that's true.
Perfect. Okay, sounds good. So why don't we do this? Let's have Oppie, do you want to start? So Yuri's going to give us the first chunk of information, and then you'll have the microphone to just kind of walk through the data he's given us, tell us what you think. And then, I'll kind of add anything, any other thoughts. And then for aliquot 2, Taylor will take the mic, and then Robbie will follow up from there. So let's do it.
Awesome. Let's rock and roll.
All right, let's go. Can I start?
Please.
All right. So we're dealing with a 24-year-old male with a 1-day history of exertional chest pain who presented after an episode of loss of consciousness. And that's the end of aliquot 1.
Perfect. I mean, that gives us so much to go on. So Oppie, do you want to go for it? What do you think about when you hear about this 24-year-old with chest pain and loss of consciousness?
Yeah, so that's interesting. So I think for loss of consciousness, I'm thinking about whether it's syncope or seizure, all kind of that stuff combined with the exertional chest pains. I'm thinking about cardiogenic in origin. It could be, arrhythmogenic induced syncope or structural heart disease that causing both exertional chest pain and consciousness. And interestingly, because he's only 24, so I'm kind of thinking more about arrhythmia in origin, although structural heart disease cannot be ruled out. Some of the structural heart disease that I'm thinking about is, for example, aortic stenosis, but it's less likely for 24-year-old male to have that. Other things are like, cardiac myxoma, like there's a mass in the heart that can cause, I'm not sure whether it can cause exertional chest pain or not. Other things is arrhythmia, which should not causing the exertional chest pain. So I'm more thinking about structural heart disease.
Api, what a brilliant first approach to this case. I love that. And I think in internal medicine, these two chief complaints, right, exertional chest pain and loss of consciousness, are both so common. And I think what we really need to do here is kind of think about the framework for both of them and then think about where they might overlap. His age is probably one of the most striking things here, right? We'll probably learn a lot more in the next 1 or 2 aliquots, but one of my mentors in residency said that if you have a young patient who's presenting with chief complaints like these, you might want to think about it in one of 3 buckets, maybe bad luck, bad genes, or bad behavior. So, bad luck if somebody has trauma or, some catastrophic illness that happens to them. Bad genes. I mean, we have to think about whether this is something that could have been genetic or hereditary. And then bad behavior, which I think is probably too stigmatizing. But when we think about, decisions people make or illnesses they might have, like mental illness or drug use that might lead them to have, to have certain symptoms. So I love the idea of kind of thinking about these two kind of both very common chief complaints and thinking about the overlap. And I think you identified that structural heart disease is a really big potential area for overlap. What else do I want to say here? I think I love that you talked about some of the kind of mimickers of syncope. We want to make sure that we don't just assume that all loss of consciousness is syncope. So in addition to seizure, which you identified, I want to think about hypoglycemia, although that's a little bit hard to kind of map on to the loss of consciousness, to the exertional chest pain. And maybe about posterior circulation stroke, although that would require us to have a lot more information about his history or his risk factors, because that's something we would really rarely see in a 24-year-old. So a great first discussion here.
Bravo.
Awesome.
Não mexe com esse bolso.
I think, Rafa, could you mute your mic? We're getting some background. Thank you. So yeah, you mentioned, valvular heart disease, which I think would, in this case, really most likely have to be something genetic or congenital in some way, or did he have, rheumatic fever as a child leading to valvular disease, for example? So I think we can pause there. Yuri, you ready for the next aliquot?
Oh yeah, sure. So kind of detailing a little bit more of the chief complaint or the initial presentation. The patient reported a chest pain that began 24 hours prior while exerting himself at work, which he described as substernal without radiation, pressure like 8 out of 10 intensity. The following day, the patient had worsening pain, had a brief episode of loss of consciousness without prodromal or seizure symptoms. In the ER, he was noted to be hypotensive, 90/60. His EKG showed a ST segment elevation in V4 through V6, D1 in AVL, troponin was elevated, and he was started on tenecteplase and ultimately transferred to a higher level cardiac care unit.
Whew. Wow, this case is getting more and more concerning. Taylor, where are you at with all the things that Yuri so expertly presented to us?
Yeah, so the age is really throwing me off because, as Api was saying, exertional chest pain and loss of consciousness is like very concerning for, exertional chest pain to me kind of sounds like angina. So that kind of makes me think of like coronary artery disease. And, a lot of the patients I see have like a laundry list of past medical history, and obviously they're not as young as someone who's 24. So, I mean, maybe he like had like some like a pericarditis or like a myocarditis, which could have led to like infarction. Maybe, I'm not really sure if that's a thing. But I mean, I guess it's possible, like any inflammation of the heart. I think like a pericarditis or a myocarditis is a lot more common in a younger male. I actually just took care of a young male who had myocarditis after his COVID vaccine, which I've heard there's some studies going on. So just as like a little side note, if people want to read into that, I definitely have to read into that more. He ended up being discharged, but anyway, so ST segment elevation in V4 to V6 and troponin was elevated. Okay, so I mean, I think to actually diagnose like a STEMI, we also need the reciprocal like depressions in the other leads. So I'm not sure if he had that, but he's definitely someone, if I was taking care of him, I would be calling cardiology right away. And, you know, also troponin would need to be trended every 6 hours. So yeah, my thoughts are maybe he had like some sort of infection thing that's causing this ST elevation, or maybe he has like some underlying like genetic disease where like the triglycerides are really high. I think that's a thing. And maybe he has like undiagnosed hyperlipidemia, and then he actually has coronary artery disease and is presenting with a STEMI. But he's definitely someone who's sick and someone who cardiology needs to come see right away.
Taylor, are you sure you took some time off? Because I feel like you've been in the trenches this whole time. I love the way you went through that. You were so authentic to the data that you had. Like you talked first about your differential diagnosis of chest pain, and then you used the ST elevation as to narrow your differential diagnosis. And in that differential diagnosis, I heard you articulate the tension in this case, which is that in somebody who's 75 who has hypertension, hyperlipidemia, this case is not really much of a diagnostic mystery. This is acute plaque rupture causing acute coronary syndrome. But here, I think you're worried that the patient's young age makes that diagnosis a little bit less likely. And so you started to think of other causes of ST elevations like myocarditis and pericarditis. I think that's absolutely superb. But most importantly, you ended up by being practical. You're like, listen, this guy needs an assessment by cardiology and something very, very urgent because he's pretty sick. I'm right there with you. I have nothing to add. I think that that tension is so important to tease out because when we say, I think it highlights one thing about highlights one thing about terminology. When we say somebody has acute coronary syndrome, I would love for all of us to pay attention to the words. We're saying the patient has an acute syndrome in their coronaries. That's all we're saying. And there's a reason for that. The reason that's all we can say is we, by talking to a patient and looking at the EKG, can be confident that something happened in their coronary vessels. This is why people are particular, especially experts in the field, about saying, what is the cause of the acute coronary syndrome? And in most people, the cause is that they have an atherosclerotic plaque that ruptures, causing a thrombosis on top of that plaque, resulting in cardiac stenosis, and that's the acute syndrome in the coronaries. But are there other acute syndromes in the coronaries? The answer is absolutely yes. You can get a thrombosis without a plaque from hypercoagulable conditions. You can get a cardiac embolism from endocarditis, like the infection you were alluding to. You can get coronary vasospasm. You can get coronary dissection. You can get coronary vasculitis. You can, as a young person, have anomalous, poorly formed coronary arteries that are vulnerable to compression and collapse. You can have so many things that can cause an acute syndrome in the coronaries. And so I think the tension in this case is, how good are the ST elevations at telling us that something happened in the coronaries? And the answers are pretty good, but they're not perfect. PE, pericarditis, Takotsuba's cardiomyopathy, all sorts of things can cause ST elevations. Arrhythmogenic cardiomyopathy, or so on and so forth. So the next step is really to call cardiology and take a look inside the vessels and make the conclusion, did this person have an acute syndrome in their coronaries? And depending on what we see in the coronary anatomy, either a plaque with a thrombus or just a thrombus or a dissection or an anomalous artery, will we be able to make progress, recognizing that all along we might have been wrong. The ST elevations are good for a syndrome in the coronaries, but they're not perfect, and we may have to remove ourselves from the vessels and provide a picture of the heart itself. And for that, I'll pass the mic back to Yuri.
All right, so here we go into aliquot 3. The patient had a past medical history of dyslipidemia, for which he was prescribed simvastatin 40 milligrams. For his social history, he faced numerous socioeconomic barriers, limiting his access to medication as well as to primary care. He reported drinking 5 to 6 cans of beer on the weekends and denied any recreational drug use. As for his exam on his admission, his vital signs were blood pressure was 90/60, heart rate 80 beats per minute, respiratory rate 18, O2 sats 95. He appeared in acute distress secondary to pain. On cardiovascular exam, he had a regular heart rate and rhythm, normal S2, S1 and S2, no murmurs, rubs or gallops. No lower extremity edema or brief capillary fill. On respiratory exam, he was in moderate respiratory distress with crackles in bilateral bases. His eye examination showed yellow color plaques over the medial eyelids in opaque rings surrounding the cornea bilaterally. His skin examination showed groups of yellow plaques diffusely, especially over extensive surfaces. And that's it.
Great, thank you. I think it is Appy's turn to jump in. What do you think about this this social history, behaviors, and exam?
Sure. All is pointing out to the familial hypercholesterolemia is interesting that he's at 24, but he has been diagnosed with the dyslipidemia already. So there should be something wrong about that. Other than that, in terms of the physical exam, it is noted that he has, I think it's called xanthelasma, right? Or I'm not sure with it. Yeah, xanthelasma. And then for the corneal ring things, that's also indicating the hypercholesterolemia as well. I'm not sure what type that is. I can't remember. Also, his lungs show that he has crackles. So probably with that blood pressure, I would say probably he is an impending cardiogenic shock from the STEMI. So I would call cards right away for sure. Yeah, and he might be admitted to ICU. I think that is what I got from here. So
Thank you so much, Appy. This case definitely just took a turn, right? I think from the beginning we were saying this guy's 24, there's no way he can have obstructive coronary disease, but I think the data that we've just gotten here really is pointing to what looks like probably familial hypercholesterolemia, right? The fact that he's had dyslipidemia bad enough in his 20s to be on lipid lowering therapy, definitely points to familial disease. And I think moreover, the presence of these xanthelasmas, as you pointed out, which are the eyelid form of xanthomas, which is a more kind of generic term for these kind of yellow cholesterol plaques that can appear kind of anywhere in the body. We heard that he had them on his skin as well, right? In addition to in his eyes. Those little rings surrounding the cornea, usually when they appear in older people, we call them arcus senilis, but I think that when they're in young people, they're called arcus juvenilis. So it's also can be a sign of cholesterol accumulation. So I think, this whole time when we were thinking about his exertional chest pain, we were saying this can't be a STEMI in the way that we normally think about a STEMI, a kind of atherosclerotic plaque rupture event, but it's sounding more and more like that based on the evidence of these risk factors. I think we still need to keep kind of non-atherosclerotic things on the differential. So that category that Robbie was saying of what's actually now called MINOCA, MI with normal coronaries. So if he does go for cath and we find that he does not have obstructive coronary disease, then we have to think about one of these other buckets, right? So anything that fits into this MINOCA category. So that includes coronary vasospasm, embolism, SCAD, spontaneous coronary artery dissection, and other things that can lead to MI in the absence of coronary disease. But in this case, I think, clearly interrogating the coronaries is going to give us more information. And I echo, Api, your concern here about this guy's not only blood pressure, because I think it's possible that he could have this normal blood pressure as a 24-year-old, but I'm very concerned about these bilateral crackles. And what I would love to hear about would be the exam of his extremities, not when it comes to the plaques that we heard about or edema, which might be interesting, but whether his extremities are warm or cool. Because I think that's, before you even get a lactate or any other markers in the blood of potential cardiogenic shock, doing a good extremity exam, looking at his JVP, trying to get a sense of whether he's perfusing, is going to help us decide kind of how urgently we need to act. I think we all recognize, based on his respiratory distress, his crackles, and his borderline low blood pressure, that the action is going to have to be quick. I would argue that if we have evidence that he's that he's got, vasoconstriction, and that he's cool on exam, would make that action go from urgent to emergent in terms of how quickly we need to move him to the right setting and get him appropriate therapy. I think we're ready then for the next aliquot, right?
All right. So our patient, actually, in terms of his extremities, as you said, he wasn't cool. He was actually warm, and he had a normal capillary filling time, which was a little bit of a surprise for us, considering the case. But
so reassuring that he's probably not in cardiogenic shock, but he's clearly in acute heart failure, right? Or not clearly. I think the bilateral crackles are suggestive. We would need a little bit more information about his JVP, et cetera, to know. But I think we're getting the indication that he's in heart failure, but maybe not yet in cardiogenic shock.
Yes, sure. So he had a normal CBC, a metabolic panel. His lipid panel showed a total cholesterol of 567, an HDL of 29, an LDL of 318, and triglycerides of 82. He underwent a coronary angio, which showed triple vessel disease with 90% stenosis of proximal LAD, as well as complete occlusion of middle segment of the circumflex artery and RCA. He had a TTE, a transthoracic echocardiogram, which show preserved ejection fraction and no wall motion abnormalities. That's it.
Ooh, alrighty. We asked and I think we received. Taylor, where are you at with all this data?
So I think that it's very interesting that his echo has no wall motion abnormalities, but he has triple vessel disease. That's really throwing me off. Because every echo I've seen in someone with coronary artery disease has, some sort of akinesis somewhere. Even if it was an old MI, the echo still shows wall motion abnormalities. So that's really throwing me off. I'm a little bit like patting myself on the back with the fact that I kind of came up with that maybe he has this familial dyslipidemia thing. So, I'll just pat myself on the back. I do that on the wards too. When I figure out something that my attending missed, I'm like, oh, Taylor gets a point. But anyway, so, that's just interesting. That makes me think maybe this started, in the coronaries themselves. But I feel like the fact that he has this dyslipidemia, he has limited access to healthcare. Maybe he, hasn't been able to fill his atorvastatin, as he should. Obviously the cholesterol is high, but the other numbers, I would just have to cheat and see what the normal range was. So I am stumped because I've never seen a normal echo and an abnormal cath. And I see a lot of cath patients where I work. So that I would just be asking cardiology for help at this point. I would just be like, what are the next steps? Help me out here. So that's really the only thing I could think of that maybe it is one of those other categories of something like within the coronaries. But I'm definitely excited to learn a lot from this case. So let's see.
We ask ourselves all the time on CP Solvers, like, what defines a good reflection or a good conversation in response to clinical data? And I think if anyone is able to both pat themselves on the back authentically, as you just did, for very good reason, and everyone listening to this call will definitely agree that you definitely deserve to pat yourself on the back for your prediction of this. But then interject with tremendous humility about reasons why you need to learn more to pat yourself on the back the next time. And I think you just did that so well. I really proud is the wrong word. I really admire your reflection and your ability to both be like, you know what, I did really good, and I want to do better in this domain, and we'll learn from cardiology and learn from this conversation. And I too will learn along with you. I think it's humbling. I think I have two reflections. It's humbling how all of us are inclined to think that the younger the patient is, the less likely they are to have a sinister cause of chest pain. And that is true. The vast majority of patients that I see in the emergency room who have chest pain, I discharge. But that's because the vast majority of people have less sinister diagnoses does not mean that the things that are scary don't exist. And in fact, as a diagnostician, if you zero in on the things that are scary, it turns out that is a longer list of diagnoses to entertain in younger patients with chest pain. And here's the perfect example why. Any disease that you can think of as a cause of chest pain in older adults can affect young people. And that may be because of the rising incidence of the obesity epidemic or genetic diseases that mimic diseases of older adults. But there's a spectrum of diseases that are unique to younger people, in addition to considering all the things that affect older people at a younger age. There's some diseases that only affect young people. Examples: bicuspid aortic valve, hypertrophic cardiomyopathy, atrial myxoma, congenital anomalies, so on and so forth. So it's kind of tricky because younger people tend to have less severe diagnoses. But the range of diagnostic possibilities in younger adults includes anything that an older adult can be affected by and some more. This, by the way, is the same reason we tend to LP people who are younger when they come in with altered mental status compared to older people. Younger people are much more likely to have, younger people are just so unusually altered that we jump to LP quicker instead of doing the same in older adults. So what's your biggest takeaway? Your biggest takeaway is you have a very hard job, because I will tell you that most people with chest pain have benign diagnoses, but the list of possibilities of chest pain in younger adults is anything that an older adult can be affected by and some other less common things that are unique to younger adults. So if you take the whole pie is actually like 90% of it is benign, but that 10% includes everything that can affect an older adult and younger people. So you really, really have to be on your toes. And I think kudos to everyone involved in this case for being on their toes and figuring out this diagnosis here. The other dimension to reflect on is the thing that you picked up on. Why is the echo normal in the face of such extensive disease? And I think the lesson I continue to be exposed to in medicine is the role of symmetry. This comes up in patients who we use pharmacological stress testing on. And the short version of this is whenever there is balanced disease or symmetric disease, there can be a global reduction in function without asymmetry. So if you have disease in every single vessel, it may affect your echo in equal proportion everywhere, resulting in an interpretation that there are no segmental changes because every single segment is affected. And that's the most common reason why patients with advanced coronary disease have no segmental changes is every segment is affected. But I have rambled enough, and actually, because this is the final aliquot of data, we'll pass the mic. We'll pass the mic back. We'll pass the mic back to you, Rebecca, to see if you have anything to add, and then we'll reflect on the case.
Yeah, I love all those reflections. I think, similarly, I think to Taylor, I was kind of trying to kind of put this echo into context. I think The one thing I'll just clarify is that I think not every patient with coronary disease will have an abnormal echo. We see tons of patients with coronary disease, right, who have normal echoes, and that's because they've never had ischemic events large enough to cause territorial infarction, which is really what you would need in order to have a wall motion abnormality, right? You would need to have enough ischemia to cause an infarct that then leads to the wall motion abnormalities. What I'm surprised to see is that he has not just coronary disease, but he's got something called a CTO, a chronic total occlusion of 2 of his vessels. And one thing I love just from a teaching perspective is that those vessels are exactly where you would expect them to be based on his EKG. So he had elevations in V4 to V6, right? V1 and AVL, right? So he has kind of high lateral and lateral ST segment elevation, which is exactly what you would expect for a left circumflex lesion. But the fact that he has chronic total occlusion, and I'm trying to piece that together with the echo, maybe because he's had this disease for so long, he's developed tremendous collateralization. And it very well may be that the perfusion to his myocardium is preserved because of how long-standing his disease is. And because he's somebody that, you know, has been living with this for probably since he was, you know, a child. Based on the xanthelasmas and the fact that we know he's had dyslipidemia, which was diagnosed a long time ago. And so I suspect, and I don't know if there was any data on this on the cath, that he probably has pretty significant collateralization, which leads to kind of overall intact perfusion, right? Because a chronically total occluded vessel typically would give you infarction leading to wall motion abnormalities. So in that case, on top of his very bad genes, he has a little bit of good luck when it comes to that collateralization, which has left him with a preserved EF. The thing I'm still struggling with is his loss of consciousness. You know, I think we were trying to decide kind of whether we wanted to call this acute heart failure or cardiogenic shock. And on the one hand, I think the fact that he lost consciousness suggests to me that, you know, he had some hypoperfusion event to his brain, right? His blood pressure must have dropped far enough to lead to that hypoperfusion. So by definition, in the same way that syncope in the setting of PE, we sometimes kind of will put that PE into the massive category, saying it was big enough to cause hypotension. You know, do we make that same analogy here and say maybe he was in cardiogenic shock? Maybe at the time he was having a kind of acute ischemic event, he temporarily lost enough cardiac function to develop kind of a transient drop in his EF. But, you know, I can't figure out why he's even in acute heart failure per se, right? He hasn't lost his EF. So maybe he's lost some of his diastolic function that's led to some you know, left-sided disease causing this pulmonary edema. But I think that those are still some of the things I'm struggling with, right? Why does he lose consciousness? Did he have a transient drop in his EF or a transient kind of dramatic drop in his diastolic capacitance that led him to develop this heart failure? But you know, again, for the most part, I think this guy had tremendously bad luck in terms of his genes. And on top of, unfortunately, a bad luck in terms of his social situation, the fact that he didn't have great access to healthcare, I think, you know, consistent adherence with a statin, and in this case, probably more than a statin, right? Probably would have ideally benefited from either ezetimibe or a PCSK9 inhibitor, if those are available where he lives, to bring down his cholesterol far enough to try to avoid events like this in the future.
I have a question actually. So I think there can be, like, you know, secondary hypercholesterolemia as well. For example, like nephrotic syndrome or like hypothyroid. But I'm not sure whether those conditions can cause the xanthelasma, like xanthoma or not.
That's a great question, Api. To my knowledge, the type of secondary hyperlipidemia that you would get with the nephrotic syndrome or with hypothyroidism is kind of modest elevations in the total cholesterol. So I've seen people with cholesterols in the 300 range, LDLs in the 200s. And I have not seen levels this high with a total cholesterol in the 500s, LDL in the 300s. And importantly, as you identified, I don't know those conditions to be associated with the xanthelasmas. I think those are pretty classic for a familial or genetic hyperlipidemia. But I'd be happy to hear about some of the other veterans in the chat to see if anyone else, Dr. Centaur or Robbie or anyone else has experience with xanthelasmas in non-FH conditions. Hearing none.
Nada.
Awesome. Yuri, I'd love to hear from your guys' perspective what you thought about the loss of consciousness episode, and then also what you thought about kind of his development of acute heart failure in the setting of what looks like a preserved EF, at least at the time it was measured.
So actually, the medical team thought of the loss of consciousness as being a VTAC or some arrhythmia that he may have developed and went out of it during the episode of ischemia. He did present with some degree on examination, some findings that were suggestive of heart failure. That was a real surprise for us when we had a preserved EF. However, the thing is, I only got in contact with this patient on his tertiary care unit. So that was about 21 days after the index event. And unfortunately, a lot of data went missing on this transportation process. And we kind of lost the history a little bit on this one. So maybe there is some inaccurate physical examination data going on here, but to be honest, it was a surprise for us too when we got the history and had to preserve ejection fraction, because we were expecting a guy with a very decreased ejection fraction and very advanced heart failure, but he was actually doing okay.
Thank you so much. The idea of it being a transient arrhythmia makes a lot of sense here, especially if it was in the setting of an active ischemic event, right? So some of the most common causes of VT or arrhythmia would be active ischemia, right, which was the hypothesis here. Old scar, which it doesn't look like this gentleman has, right? At least he doesn't have any wall motion abnormalities. It doesn't look like he has an old scar. Or then things like severe electrolyte abnormalities, which we didn't hear about, but it sounds like you didn't have access to all the data. I'm glad to know that's not a problem unique to our systems here, that a patient might arrive from a different hospital with very incomplete information and you have to kind of piece things together from what happened a week or two ago. So I think that sounds like it's a global and universal problem. So yeah, the idea of it being an arrhythmia is really interesting. I'm curious to know if, being on telemetry at their hospital or your hospital, if that arrhythmia had ever recurred, because that, the fact that it was with a episode of syncope without prodrome is definitely kind of, at least based on the kind of classic textbook definition, something that speaks more to an arrhythmogenic cause. Remembering that there's other kind of cardiogenic causes of syncope, and I think Zavin tweeted about this today. That not all cardiogenic syncope is unheralded, lack of prodrome. There's plenty of cardiac causes that can present like orthostasis, structural heart disease, things like that. But arrhythmogenic cardiac syncope is really the one that classically will present as a kind of unheralded, sudden onset syncope without a prodrome. Great case. Robbie, any other last thoughts? We can move on to teaching points in a minute.
All right, so Wendy out here. I'm really thankful, Yuri, for presenting such a wonderful case. And honestly, if you look back at the discussion, it shows you that if you're training in internal medicine or really learning in any way, shape, or form, the learning and development of all of us is constant. And I'm just so mesmerized by our guests. And to consider yourself a guest, I think, Rebecca, is silly. You're really a part of the VMR family, and it's so excited to be able to facilitate with you. So thank you to everyone for joining us. It was amazing.
Excellent. Valeria just asked if xanthelasma could be seen in primary cholangitis. I don't remember, but I'm going to look that up while we start to hear about teaching points. I think Gerline, you're, oh, sorry, Yuri, the final diagnosis. I think we've all implied what we think it is, but why don't you give us the final word here from the primary team?
All right, sure. So I'll finish up with the case conclusion, and then I'll go forward with a few teaching points. So he was, just as a recap, he's a young patient with an acute STEMI triple vessel coronary disease, and he was diagnosed clinically with familial hypercholesterolemia. The loss of consciousness was thought to be due to some form of arrhythmia, maybe a ventricular tachycardia, in the setting of a myocardial ischemia. He underwent a CABG without any post-op complications. On discharge, he was started on metoprolol, nalopril, ASA, clopidogrel, atorvastatin, 80 milligrams, ezetimibe, and evolocumab, which is a PCSK9 inhibitor. Upon further review of this patient's family history, he had multiple older family members with early onset acute coronary syndrome. Additionally, he had 8 young siblings with similar physical examination findings of eruptive xanthomas, and his family was invited to screen and for genetic testing as well to try to prevent and detect early coronary pathologies. As a teaching points, although plaque rupture still remains the most common cause of ACS in patients under the age of 45 years old, we always have to think a little bit of a non-atherosclerotic causes, sorry guys, of ACS in this age group when compared to older populations. So we're thinking a little bit of a spontaneous coronary artery dissection, coronary vasospasm, vasculitis, coronary embolus, myocardial bridging, and some other etiologies. And in the absence of obstructive coronary artery disease, especially in younger patients, a high index of suspicion for these causes is necessary to find the appropriate diagnosis and treatment approach. As kind of the second teaching point, familial hypercholesterolemia is an inherited disorder of one or more genes involved in the LDL catabolism. The disease characterized by high LDL levels, increased risk for early onset atherosclerotic disease. Familial hypercholesterolemia must be distinguished from other causes of hypercholesterolemia, xanthomas, or premature cardiovascular disease. There is a criteria that we can use to clinically diagnose the patient, and we actually use this criteria on this patient, which is the Dutch criteria, is the most widely used. There is a couple of others more, but it's the widely used scoring system for familial hypercholesterolemia. It takes into account 11 parameters grouped into 5 categories, which is family history, clinical history, physical examinations, cholesterol levels, and DNA analysis to predict the likelihood of having familial hypercholesterolemia. And remember that is a relatively common condition that affects approximately 1 in every 500 patients in its heterozygous form, and 1 in every 1 million patients in homozygous form. Therefore, heterozygous is more common. It is, however, more prevalent in some populations, namely South Africans, Lebanese, and French Canadians. There are over 1,600 gene mutations implicating the pathogenesis of familial hypercholesterolemia, which with a wide range of phenotypes and outcomes. Therefore, the presentation can vary a lot depending on the patient you're dealing with. And the most common mutation, which accounts for 85 to 90% of the cases, involves the LDL receptor. Other common mutations involve the ApoB protein and the PCSK9 protein. On average, an affected adult has 30 to 50% increased risk in cardiac event by the age of 50 in men and by the age of 60 in women. As a result, aggressive cholesterol management in early familial screening and diagnosis is necessary, as it has been shown to greatly decrease mortality. And just a last remark, I think this case was interesting to me because, as I said, I only got in touch with this patient on his 21st day of being followed by a medical team, and nobody actually had suspected of familial hypercholesterolemia. Nobody was investigating it. So we sometimes see an ACS, we tend to diagnoses, but as Dr. Nick said, we have to always look for, what is obstructing the coronary, what is causing the acute coronary syndrome, and looking for a cause. So that was interesting to me. That was it, guys.
Yuri, that was unbelievable. Unbelievable teaching. Such a great overview of the importance of suspecting this and how to diagnose it and how it presents. It was really, really well done. I also might have heard you say Lebanese in there, which really got my my attention because of my own ethnic background. So thank you for this is a really important piece of information for me personally. And I can't think of anyone else to wrap up the teaching from today than our almost certainly cardiology-bound guru, Gurleen. So please take it away, Gurleen.
Thank you so much, Luri, for presenting that case. It was really interesting, and I learned a lot from the discussion. So when we started off with this case, we were thinking about how to approach syncope. So when we're thinking about patients with syncope, we want to first make sure we're ruling out any mimics. So that includes things like seizures, strokes, or hypoglycemia. And then when we're thinking about syncope overall, we're thinking about 3 different categories: cardiogenic causes, orthostatic, or vasovagal. So one way to approach syncope is to think about that there's decreased blood pressure or decreased perfusion to the brain, which is causing loss of consciousness. So we know that the mean arterial pressure, or MAP, equals cardiac output times your systemic vascular resistance. So your perfusion might be low because of decreased cardiac output or because of decreased systemic vascular resistance. So when we're thinking about different causes of decreased cardiac output, that could be cardiogenic in nature, which could be obstruction, such as aortic stenosis or hypertrophic obstructive cardiomyopathy, or it could be arrhythmias. And then the other category of decreased cardiac output might be hypovolemia, which could lead to syncope. And then when we're thinking about decreased resistance, that could be decreased sympathetic tones, which could be due to medications causing syncope or other diseases that lead to decreased sympathetic drive. Or it might be an increase in the parasympathetic system, which could be related to vasovagal syncope, which is leading to your decreased resistance and then therefore syncope. That's one way to think about it. But when we're trying to approach and figure out what is more likely than other things to keep in mind that signify a cardiac cause would be symptoms that are worse with exertion. Also, if there's no prodromal features, but as we learned that some of those, the absence of prodromal features is more likely in arrhythmogenic causes of syncope, and other cardiogenic causes might actually present with symptoms depending on if it's obstructing flow like aortic stenosis, that could be volume dependent. So it could be affected by orthostasis and things like that. Other things that would signify a cardiogenic cause would include abnormal EKG, as well as baseline disease, looking at who our patient is and what the risk factors are. Then the other aspect of this case is the chest pain and the troponin elevation. So when we're thinking about troponin elevation overall, the different categories to think about it is it a decrease in supply? So decrease in supply could be because of an acute coronary syndrome, because of actual plaque rupture and thrombosis, like a type 1 MI, which you would see things in the cath lab when you send the patient for an angio, or the decreased supply might be due to a MINOCA, which is myocardial infarction with no obstructive coronary disease. And that could be due to things such as dissection or vasospasm. And then when we're thinking about chest pain in this patient, in a 24-year-old, usually in younger patients, we're thinking about more benign causes, but we need to remember the emergent causes of acute chest pain, which include cardiac things such as ACS, aortic dissection, cardiac tamponade, and Takotsubo's cardiomyopathy, but also pulmonary things such as pulmonary embolism. And then in this case, when we're thinking about younger patients usually having less severe causes, we have to remember that they can have the full spectrum of disease of both disorders that are more common in younger patients, like hypertrophic obstructive cardiomyopathy or other congenital anomalies, but also they can still have risk factors that put them at a predisposition to diseases that we most likely assume with older patients, like hyperlipidemia and those risk factors that we typically attribute to acute coronary syndromes and obstructive coronary disease. And then when we're thinking about ST elevation, we're thinking about ACS and MI, but also to remember other causes like myocarditis and pericarditis, and looking at the localization of EKG patterns to help us figure out where the lesion is. So with ST elevations in 2, 3, and AVF, which is the inferior leads. We're thinking about lesions in the right coronary artery, and then V2 to V4 and V1 to V2. We're thinking of the anteroseptal and anterior leads, so thinking about something going on with the LAD. And when we're thinking about 1 AVL, V5 to V6, we're thinking more of a lateral localization, so thinking about the circumflex artery. And then in this case, the things that really helped us were the physical exam clues for the familial hypercholesterolemia. So this is, as Luri recapped really well, an autosomal dominant or codominant condition due to receptor mutations in LDL or other gene mutations. And in this case, the clues that were really helpful were the corneal arcus, or the rings around the cornea, as well as the xanthelasmas, which are cholesterol deposition around the eyelids. Other things that are very specific for familial hypercholesterolemia are tendon xanthomas, which is cholesterol deposition. It can be like in the Achilles tendon, if the Achilles tendon is enlarged more than 8 millimeters, and that's due to cholesterol deposition in the macrophages. And then the other aspect in this case was the patient's vital signs, the low blood pressure, and the shock. When we're approaching shock, thinking about cardiogenic shock, we want to assess the stability of the patient and how, if it's wet or cold, looking at perfusion of the extremities. And then the other interesting aspect of this case was the normal preserved ejection fraction, but the severe disease in the cath that results. So when we're thinking about the law of symmetry, if a disease is present in every single vessel, then there might not be segmental changes found because there's no asymmetry. All of them have equal obstruction. And then when we're thinking about chronic occlusion, which was the case in this patient, you can have a preserved ejection fraction because of collateralization and blood flow that develops slowly over time. So that's important to take into consideration. And then overall, when thinking about arrhythmia such as VTAC, is it because of ischemia and myocardial disease, or is it because of electrolyte abnormalities? And thinking about other causes that might not be directly related to the cardiac tissue or the ischemia that are causing the VTAC. So those are some of the teaching points, but this is such a great case. I learned so much.
Thanks all. And I think making VMR history, we are finishing on time at 9:30. So it's been such a pleasure to have a chance to discuss this case with everyone. Thank you, CP Solvers, for having me. And I hope to see you guys all again soon.